Okay, as you people know, today the topic of our discussion is myocardial perfusion scan or myocardial perfusion imaging. The learning objectives of today's session are going to be understanding the basics of MPI, that is myocardial perfusion imaging, exercise versus pharmacological MPI, interpretation and applications. As I have different categories of residents, so we will try to discuss from the basics so that everyone can understand. If you have any queries, then you can ask in the comment section. So myocardial perfusion imaging is mostly utilized modality for the assessment of myocardial perfusion and viability. Okay, two things. That is assessment of myocardial perfusion, in which mainly we are assessing the ischemia and the viability of the myocardium, whether the myocardial cells are alive or not. Its sensitivity is around 90% and its specificity is around 74% to detect this thing. Okay, the basic principle. Everyone has to understand this thing. Okay, how actually it is going to work. As we inject an isotope, which most of the time we are using technetium, from the blood stream, viable myocytes are going to absorb that isotope. In this illustration, it is representing the thallium which we were using in the past, but because of its longer half-life, we are no more longer using it. So as the blood flows through the myocardium, myocardial cells are going to absorb the isotope. This absorption depends upon the blood flow. A cell or the region of the myocardium which has increased blood flow, better blood flow, is going to absorb more isotope from the bloodstream as compared to a ischemic myocardium or the myocardium which has decreased blood flow or has no blood flow. This is the basic mechanism. And as this isotope is going to absorb into the myocardial cells, later on the emitted radiations in form of photons are going to be detected by the SPECT machine and is going to be further processed by the software and going to show in form of a display. So this is the basic mechanism. Everyone understand this? Okay, how this is going to work? Basic physiology is clear to everyone? So if you understand this thing, then you can proceed further. So this is a myocardial perfusion scan, how it is going to be look like. You are going to see bright spots or dull spots, different regions, depending upon the uptake. This is the, on the rightmost side, this is the panel here. This is going to be the region of the myocardium which has absorbed most of the isotope. And if this is the color which is going to be appear, it means it hasn't absorbed any isotope. And in between, if you are going to appreciate this type of color on the scan, then it means it has absorbed a moderate amount of the isotope. So on this scan, as you can appreciate that these are the bright area, it means it has absorbed good amount of isotope. This is the area which is appearing like this, the greenish one or the blackish one. It means it hasn't absorbed any isotope. And this is the region which is midway. It means it has absorbed some isotope, but not fully. So this is how it is going to appear, the basic physiology. of the myocardial perfusion scan, that the bright spots or the visualization you have is going to be dependent upon the blood flow to the myocardial cells and the viability of the cells, how much isotope from the blood they are going to absorb. And one thing, this flow chart, I hope you know, this is called ischemia cascade. So in this ischemia cascade, as the process of ischemia begins, okay, with flow distribution, okay, blood flow distribution, the first thing after some biochemical changes inside the cell is going to happen is a perfusion defect. Meaning the earliest presentation for to detect ischemia is to be detected by this nuclear cardiology, either the PET scan or the MPL or the SPECT myocardial perfusion scan, this perfusion abnormality when there is disturbance in blood flow or disturbance in distribution of the blood. And afterwards, diastolic dysfunction starts occur, systolic dysfunction, and then the ECG changes. When patient is presenting you with chest pain, with ECG changes, then all these changes have already occurred. And after ECG changes, this is the pain, angina, okay, which is going to occur. Or it means if a patient is going to present to you and having pain and have no ECG changes, okay, it means that ischemia, that pain is either secondary to something else, or the ischemia is not that much to produce any significant ECG changes. Otherwise, considering the ischemia cascade, the ECG changes, these all things are going to occur before patient is going to have pain. And in this ischemia process, the earliest thing which is going to happen is a perfusion defect, which is detected by myocardial perfusion scan. So previously we were using this system for the detection of this perfusion defects, but because of its longer half-life and lesser electron volt or photons it transmit to the SPECT machine, it is no more longer used now. Technetium is a better isotope which provides photons of increased voltage, produce a better image, has a shorter half-life. That's why it is commonly used now. With technetium, if we only inject technetium into the bloodstream, it can be absorbed by the thyroid, can be absorbed by the bones, it can absorb by the other organs as well. To increase its uptake into heart only, we add a tracer agent with it. That is systemimide, tetrophosphine, and tiboroxine. So these are the tracers which are attached with the technetium so that it can be absorbed more efficiently by the myocardial cells. Of these three tracers, the FDA approved are two, systemimide and the are commonly utilized in the myocardial perfusion scanning process. So this is differential washout, as you see here, a thing written myocardial clearance for the thallium and for the isotope tracer tiboroxine. What is this clearance? As blood flow through the myocardial cells, as blood is flow through the myocardial cells, then after it has entered, the tracer has entered, as the tracer has entered into the myocardial cells, see this is showing the isotope is entering into myocardial cell. The red one is showing a diseased myocardium having lesser blood supply because of some coronary stenosis. There is some stenosis here, or you can appreciate it on the top as well. Here, okay, this one. So this is a stenosed coronary having a plaque inside, interrupting the blood flow. This is a normal coronary, 1 and 2. So this one, which is diseased coronary, the myocardium is going to have lesser blood supply and the normal myocardial cells are going to have increased blood supply and increased pressure uptake. And what happens once it has entered, the isotope has entered inside the myocardial cells from the normal cells, from the normal cells, it is going to come out earlier at a quicker rate. It has absorbed initially and then it started coming out of the cells back into bloodstream. This is called redistribution. Okay, once it enters and then it comes out back. But from the diseased myocardium, it enters, but it come out at a slower rate. That it has entered, a lot of amount of isotope has come back, but from the diseased myocardium, it hasn't. So this is called redistribution. This redistribution occurs for this thallium and the technetium T-boroxine, but not for the systemine and tetrophosphate. A technical point if you want to remember. Okay, then for the thallium, which is not used of historical importance, only a few points about it. That the initial injection at peak stress, we are going to discuss further how the task is being done. But before going into that detail, we usually done it in two stages: stress and rest. Stress, in which we ask patient to do exercise or increase the heart rate using the pharmacological agents or dilate the coronaries. And at rest, we just in the resting stage, we are going to scan the myocardium. So at stress images, thallium in initial injection at peak stress and immediate imaging 5 to 10 minutes after injection. By early imaging, because as we discussed, it is going to redistribute. So early imaging is important. Okay? Otherwise, we are not going to have a clear picture. Followed by redistribution images 3 to 4 hours after injection. So what will happen? Using a same injection, for example, this is the region which has absorbed at stress the isotope. Again, this is also the region. So when we image it after stress, if it's viable, it is going to appear more brighter. But after redistribution, it is going to appear less bright because the isotope has come out of it. So we are going to scan it using a same injection. We can scan it twice at rest as well as after stress. But for the technetium, we need 2 injections because it remains fixed in the myocardium. It's not going to come out. Then for the technetium, because of lack of redistribution, we need 2 images. One at rest and other at exercise. So commonly we have a exercise image first, in which we inject a higher dose of isotope, and in the rest of images we use a smaller amount of isotope. Okay, you don't have to remember how much isotope is being injected. That is to be known by the technician. You just have to remember, okay, this is done in 2 stages: rest and peak exercise, which are usually done around 4 hours apart, so that the myocardium, which has previously absorbed the isotope may undergo decay. It goes clear from the myocardium itself, undergoing the decay process of radioactivity, and then we are going to inject the second one. Okay, if a patient is quite obese and imaging is not good, then we can utilize a separate day protocol as well, in which in the rest as well as both in stress, we are going to inject higher amount of isotope to improve the imaging in such patients. If obese patient, not clear images, so then a 2-day protocol can be utilized. Commonly, technetium scanning is done in a single day. So in the learning objective, here we are done with the first part, that is understanding the basics of MPI, how it's been done and what actually it is. So just recalling it, the whole process of this myocardial perfusion scan is going to be dependent upon the blood flow through the myocardium. A myocardium who has diseased vessel, stenosed vessel will have a lesser amount of blood flow, and these myocardial cells are going to absorb lesser amount of the isotope, and ultimately they are going to be appear less brighter on the skin. And the myocardium which has a normal coronaries, no compromised blood supply, is going to absorb more isotope and is going to appear brighter. So till here, if you have any queries,
Yes.
you can
Sorry.
ask. Otherwise, we can move to our next
Yes,
part.
Danish. Yeah.
Yes, sir.
Danish, before, sorry, this is Dr. Zahid. Before you proceed further, because we have first years also for cardiology PGs, can you make in just simple few lines, basically the difference in the protocol and the mode of action with them? You
The
did it
protocols we are
nicely.
going to
Can you
discuss
just
in the
recap
coming slides.
us later? Okay. So at least can you recap the mechanism, the difference between the technician
Okay,
system
okay, I
BV
can
and the
recap.
thallium very in 3 lines, so they can recap everything. So it can be more easily for them to understand
All right. So
in
the
simple
basic
words. In
mechanism,
simple
just
words.
recapping it, the basic mechanism of this whole myocardial scanning process is going to be dependent upon the isotope and the uptake. We inject commonly the technetium isotope into bloodstream. This isotope is absorbed by the myocardial cell, the heart. If myocardium is diseased, blood flow will be less, then lesser blood flow, lesser isotope delivered to the cells. And if it is not diseased, more blood flow, more isotope will be delivered to cells. So this is going to be appear in form of like this. If you have a brighter spot on the myocardial perfusion scan, it means it has absorbed more isotope. And if it's not that bright, it's like this, it means it has absorbed lesser isotope. Why there are differences, we are going to explain it later on in the upcoming slide. But the basic mechanism which we're discussing is like this. So from here, moving further, the next part is different protocols, the exercise versus pharmacological MPR, or we can call physiological versus pharmacological MPR. So exercise stress testing, in which patients are asked to do a treadmill exercise or bicycling in order to increase its heart rate. You know that ischemia is produced by demand supply mismatch. A patient who has a patient who has a diseased coronary, there's some presence some stenosis here, but and blood is flowing through this disease vessel, but the heart upfront present at rest has no ischemia because the blood which is delivered to it is sufficient for the working of the heart. But as the heart rate increases, its demand increases, but this diseased coronary is not no more longer is going to provide enough blood to the heart. Then there comes a demand supply mismatch. And when this demand supply mismatch comes, then this whole ischemia process, ischemia cascade going to come into play, and patient is going to have pain. So in the exercise stress testing, what we are going to do, we are going to increase the heart rate by asking the patient to do some exercise. Commonly, we ask the patient to run on the treadmill, increase the heart rate to produce ischemia if we are suspecting it, and then we are going to inject the isotope. So when we are going to, for example, if the resting heart rate, or just recalling your concept, MPH, maximum predicted heart rate, so which is calculated by 220 minus age of the patient. A patient who is 50 years of age, 220 minus age of 50 is going to be 170. So in exercise stress testing, what we are going to do, we are going to achieve 85% of age predicted heart rate. That means around 170, 85% is around 150. So we are going to ask the patient to run on a treadmill. As heart rate is going to increase and reach that 150 mark, then we are going to inject the isotope. And as we inject the isotope, for example, this is the normal coronary and this is a disease coronary. The part of the heart at this age predicted heart rate, which is receiving the normal blood supply, is going to receive more isotope, and the disease part is going to receive lesser. All demand is equal on the disease part as well as the normal part. But because of the stenosis, one is going to get more isotope and another is going to get lesser isotope. And in addition, one more important point, coronaries, normal coronaries can dilate 3 to 7 times in response to stress. Normal coronaries can deliver 3 to 7 times more blood in response to stress. So when the heart rate is going to increase, these coronaries are going, the normal ones are going to dilate and deliver more isotope to the normal part of the heart, as well as the one which is disease is going to have lesser amount of isotope. And in addition, one important point, if you have understood till now, one very important point, as the normal coronaries are going to dilate, they are going to steal the blood from the disease part of the heart. Stealing, I hope you know what is stealing. When there are two coronaries, one is this one, another is this one. Initially both are of normal caliber, but this is the normal one which dilates in response to stress. This is the disease one which is no more longer able to dilate. What will happen now? When blood flow comes, it has dilated, so more blood will go toward this part of the heart. So this is the disease one which was already receiving lesser blood, and because of this dilatation, it is going to get further less blood. This is called stealing phenomenon. So when we are going to increase the heart rate in response to exercise, then there is going to occur a disproportion or a distribution difference of blood, and the disease part is going to have lesser amount of blood flow, ultimately which will deliver less isotope to the disease part, and the normal part or the normal coronaries are going to deliver more blood, more isotope to the normal part. So this is how exercise stress testing is done. 85% of the heart rate is achieved, or the heart rate is increased, and then we are going to inject the isotope, and then we are going to scan it. If patient is not able to do exercise because of some joint issues, or is going to fatigue easily, and we are suspecting that the amount of exercise which the patient will do is not going to achieve our target heart rate, in that case we are going to do a pharmacological stress testing. In the pharmacological stress testing, as the name indicates, use drugs. We have two categories. One is vasodilator stress testing, and another is dobutamine stress testing. In the vasodilator stress testing, we have three vasodilators, that is dipyridamole, adenosine, and regadenosine, which we can use to dilate the vessel. Their mechanism is almost the same. When dipyridamole is given, it's a vasodilator test. When a dipyridamole is given, it is going to inhibit this enzyme, adenosine deaminase. ADA, adenosine deaminase, inhibits this enzyme, and this enzyme is involved in breakdown of adenosine, which is naturally produced by the coronaries endothelial cells for the dilation of the vessels. So as dipyridamole inhibits this ADA, adenosine is going to accumulate, and as this amount of adenosine is going to increase, it is going to dilate the coronaries. Or we can directly make use of adenosine, or the third one is regadenosine. And regadenosine is very selective alpha-2A receptor agonist, is only going to act on the coronary. Problem with the adenosine is that it's going to have its receptor on the lungs as well, in the bronchioles. And as we inject adenosine in form of, as well as it requires an infusion as well because of its shorter half-life. As we inject it, it's also going to act on the bronchioles and is going to produce bronchospasm in susceptible individuals. So the main advantage of the regadenosine is that that is very selective. It's only act on the corneas, as well as with the dipyramidol is as we injected, adenosine is going to accumulate in the bronchioles and it can also provoke vasospasm as well. So in the vasodilator testing, we can make use of these three ones commonly, which we are using dipyramidol with the name of Persentin. So using Persentin test or dipyramidol test as we inject it is going to vasodilate the corneas. And as it vasodilates the corneas, again the same thing comes. It's going to produce a disproportion of blood flow toward the diseased myocardium and the normal myocardium, and all that which we have already discussed is going to happen.
Yes, Danish, one more thing. I mean,
Yes,
like in US, no one is using adenosine anymore. Okay, so everyone is using Regdenosin. The reason you already explained, the difference between adenosine and Regdenosin
yes,
is, of course, the research.
because of adenosine is preferred, but we don't have its availability. That's why we are using dipyramidol.
Yes, I mean, because Regdenosin act on receptor A2A. So, I mean, that when they did, there were two major trials on it. One was advanced MPI trial, and one was the expert. What they found, I mean, compared to Regdenosin and adenosine, is that was, I think, what was that trial? Advanced, yeah. When they compared this, what there was no additional benefit. I mean, both equally good. I mean, the only problem is that the advantage was using Regdenosin as less side effects, which is very important. When they did another trial, I think it was expert MPI trial, in which what they found people when you do put them on exercise, many of these patients they do submaximal stress testing. You may not know how much they walk. Many people they do submaximal tests. What they did in this trial, they can easily switch to Regdenosin within first 3 minutes when they decided they did not achieve the heart rate. They can switch it to Regdenosin at the same time. The patients who are already with exercise perfusion. And the advantage of Regdenosin, you can switch them, I mean, in first 3 minutes of recovery, because it's just a single dose. It's not like adenosine where you have to give an infusion. So usually patient, if you have to switch to adenosine, you have to call them next day. I mean, you can't do it right away. So this is another additional advantage of Regdenosin. You can switch this patient with some maximal testing and of course, less side effect and easy to administer. So that's the reason Regdenosin has been used. Okay, sorry to interrupt you. Okay, go ahead.
Okay, all right. So these are the three ones, as sir already discussed. That adenosine, it has to be in form of infusion, and reg adenosine, it's a single bolus dose. Then move on to the other one, dobutamine. If patient has active vasospasm or has history of some airway reactive disease, so these adenosine dipyramidol can provoke it. Then we have a choice of the choice we left with is dobutamine. The mechanism of dobutamine is mainly to increase the heart rate. As we discussed, that is about demand supply mismatch. So using dobutamine, we are going to increase the heart rate of the individual and going to try to achieve a desired results. So the common adverse effects which can occur with this dipyramidol and with this adenosine, flushing, chest pain, dyspnea, dizziness, nausea, symptomatic hypertension, AV block. But as we discussed, regadenosin is selective. It's going to act on the corneas, and we are not going to have this dyspnea and AV block with this agent. And if it happens with any individual, then what you are going to do, you should have aminophylline with you, and using aminophylline, you can quickly reverse these effects. 1 to 2 mg per kg of 70 kg person, 140 mg of the aminophylline in a single bolus dose, going to reverse the effects of these dipyramidol or diazoxide. Dobutamine we have discussed. Its starting dose is 5 microgram per kg. We move up to 40 microgram per kg, and the main is to purpose of is main mechanism of is to increase the heart rate. We will discuss these things later on. Then Exercise versus pharmacological MPI we have discussed. I hope you have understand the basic protocols of using these
Sorry,
two tests.
Danish, one more question. With dobutamine, if they don't achieve the heart rate, do you add atropine routinely?
Not routinely, but it's an option as well. Using atropine, heart rate can also be achieved. So next, moving on to interpretation of MPL, which is most important, in which I guess most are interested as well after this. So how you are going to interpret? So we have different planes of imaging in SPECT, which we call as short axis, the vertical long axis, and the horizontal long axis. Okay? This is the thing which you have to understand. This is the axis. This is vertical long axis, which is longitudinal to the long axis of the heart and the body as well. And this one is a horizontal long axis, which is perpendicular to the this vertical long axis. So they are going to have these three basic curves, these three planes to visualize the heart. And in it, we are mainly visualizing the left ventricle. So this is the short axis. This is the short axis at three different levels. As you know, heart is conical shape. So these are at the levels of the base, the mid cavity, and the apex. At these three levels: apical, mid cavity level, and the basal level. And this is vertical axis. So what you have to remember, everyone needs a bit of your attention, please. So starting from the apex, just remember, as you have this donut, this is anterior, this is inferior, this is lateral, and this is septum. It's quite easier. एंटीरियर ऊपर में, इंफीरियर नीचे, लेटरल एक तरफ, सेप्टम मिड साइड के ऊपर, मीडियल साइड के ऊपर सेप्टम प्रेजेंट. So just remember this. From the apex, as you come to the mid cavity level, now again the same: anterior, inferior, septum, lateral. What you need to do now? Anterior, this is septum, you call it now anteroseptal. Inferior, inferoseptal. Lateral, anterolateral हो जाएगा. And this one, inferolateral. I recall, this is most important in the interpretation process. Okay, what is the location of the defect? For the apex, it is 4 only: anterior, inferior, lateral, septum. But at the mid cavity level, this is anterior and then anteroseptal. This one, anterolateral, inferolateral, inferior, inferior septum. Similarly here at the basal level, anterior, inferior. This is going to be anteroseptal. This is going to be inferoseptal. It is going to be inferolateral. This is going to be anterolateral. Everyone understand this. So when we have a defect, when we have a perfusion defect, how we are going to describe it? Okay, where it is present, like this. This is going to be, this is short axis, this will be anterior, this will be inferior, this is inferior, and along with inferior, there is some infero lateral involvement as well. And as we move on to these imaging planes, this is from apex toward base. These are the apical, then they come the mid cavity, and then the base. And how we are going to distinguish? At the apex regions, we don't commonly see a good cavity. As you start seeing a good cavity, it is at the basal level, and then as it's going to be blurred again, that means you are moving toward the base of the heart. So you have to understand it at the apical level, mid cavity level, and the basal level. And you are going to define it, okay, where the defect is present. Okay, everyone. And with these, the other ones, if you see a defect in the anterior segment, then this vertical long axis is also a anterior, inferior, and a apical part. If that defect is present in the anterior segment, that has to be shown here as well, in the other plane as well. Just to confirm it, we are taking it in different tomographic planes. If you have a defect here in the inferior segment, then it has to be here as well. All right. And similarly, if you have a defect in the lateral here, short axis lateral, then you are also going to see that defect in lateral. If it's here in the septum, then it has to be there in the septum as well. Why it's important? Because sometimes there may be artifacts as well, or different technical issues in which you are going to have a defect in one tomographic plane but not in the other one. Then you have to, before reporting it, you should try to confirm that it's not an artifact or it's a false defect before reporting. Everyone have understand this thing? Okay, what are different segments? Anterior, inferior, lateral, septum. At the apical level, we have only anterior, inferior, lateral, septum. As we come to cavity level, mid cavity level, then it will be anterior, anteroseptal, anterior, anterolateral, inferior, inferolateral, inferior, inferoseptal. This is anterior, inferior, apex, septum, lateral, apex. So we call it as a 17 segment model. We call it as 17 segment model. All these segments are how we are going to number them in the short axis. We just starting from the basal, move just counterclockwise. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. Okay, these are the 16 segment model of the heart. And this, 17 segment in which apex itself is the separate segment. This is the apex, which is not seen clearly in the short axis. So get foreshortened in the horizontal long axis, in the vertical long axis, we are going to see the apex at the 17 segment. Everyone understand this? So if you see a defect, in two segments, it's called a mild. 17 segments, it's present in 2, 1 or 2, it's mild. 3 to 4, it's moderate, and if it's in 5 segments, it's going to be considered as severe. Everyone has understand so far, so that we can move forward. If you have any queries till now, you can ask. Okay, if you have understand till now, so we can move further. So how we are going to report it? We are in the reporting process. Okay, we will try, inshallah. Okay, by the end of the session, you should be able to report a MPI. So how you should report? You should try reporting according to the territories, according to LAD, RC, and the circumflex territories. This anterior and anteroseptal, if you are seeing a defect in the anterior, anteroseptal, and the apical area, you should report it together because the LAD territory. If you are seeing a defect in the inferior, inferoseptal region, report it together because it's the RCA territory. And if you are seeing a defect in the anterolateral or inferolateral, then report it together. It's a circumflex territory. So when you see defect, when you see a perfusion defect, the first thing you are going to decide whether there is a defect or there is no defect. If there is a defect, then see which territory it is going to belong, in the LAD territory, in the circ territory, or in the RCA territory. You are going to report it according to the territories. So in the interpretation process, you have to define the presence, whether a defect is present or not present. Location. What is location? It's in the apical anterior region, mid anterior basal region, or where it is located. Inferior septum, inferior, inferolateral, where the location is. You have to define the presence and location. The size and severity. What is the size? small size, medium size, large size. Small size, 2 segments, moderate, 3 or 4, large size, 5 segments, 5 or more segments. Severity according to the color scheme which we discussed initially, the normal one, the more partial uptake or the no uptake. Reversibility, whether there is a defect present as the stress is going to reverse at the rest or not. Okay? We are going to see it. And presence of any infarct. If defect is present both at stress and rest, then it may represent a infarct or maybe a hypernephritic myocardium. So this is how a reversible defect is going to be look like. Commonly, the stress images are shown on the top and the rest images are shown in the bottom line. Stress, rest, stress, rest, stress, rest. So on the first 4 rows, then this is vertical long axis. It is written already. It is horizontal long axis. On the vertical long axis, we said it is anterior, inferior, apex. On the horizontal long axis, we told this is lateral, this is septum, and this is apex. And the short axis, we told you on the apical regions is going to be anterior, septum, lateral, inferior. At the mid cavity level, this is going to be anterior, anteroseptal, inferoseptal, inferior, inferolateral, anterolateral. And then as we move further, then we are going to come at the base of the heart. Okay, this is mid cavity, apical level, mid cavity level, and then the base of the heart, where this is going to be anterior, anteroseptal, inferoseptal, inferior, inferolateral, and anterolateral. You are seeing at the basal level, septum is not clear because here it from muscular it turns into membranous septum, and membranous septum is not going to have a good uptake. That's normal. That's not a defect. So what's a reversible defect? Okay, when there is decreased uptake or no uptake at stress because of the demand supply mismatch, stealing phenomenon, and as we come back to the rest, there is a good uptake. As it is showing here, at the mid cavity level, at this anterior mid cavity anterior segment, there is a perfusion defect which is reversible. At rest, there is a good uptake, and as well as in the inferior and inferolateral region. If it's in inferolateral, then you have to come and see whether it's present in the lateral segments here anywhere. No, it's not shown here. It means that it is restricted to this inferior only, not inferolateral. Anteroseptum, if is there is any on the septum defect? Okay, yes, there is some here. There is more uptake here as compared to there is anteroseptal defect as well, and on the apex as well. Okay, on the apex you can see there is return of uptake. These bright spots are here, which some here are partially reversible, means that showing decreased uptake. Here is showing uptake a bit, but it's not completely reversing, it's partially reversing. So this is showing a reversible defect. Then showing a partially reversible one, how it's going to be look like? Take it like this case is not showing uptake, it's showing an uptake, but it's not bright like this at the rest level. Okay. Here it's showing no uptake or very little uptake, and then showing uptake, but it's not that bright from as compared to the adjacent myocardium. This is a partially reversible defect. Another important thing, when there is severe coronary artery disease, then at the stress you may also see the dilatation of the cavity. Okay. Comparing it from the rest level, you can see the cavity has dilated. It is because of the endocardial ischemia. LV ventricle itself has not dilated. Okay. Clear this concept. Left ventricle itself is not. It is the endocardium which has decreased uptake, and because of that decreased uptake, it is appearing like this. So it's a high risk feature. it means patient has severe coronary artery disease. Sometimes in dilated hearts, apart from the left ventricle, you may also see right ventricle absorbing the pressure. If it is there, right ventricular uptake is also a high risk feature of myocardial perfusion scan. So a defect extent may be small, involving 1 to 2 segment. That means LV less than 10% of the left ventricle, medium 10 to 20%, and large is 5 or more segment. That makes more than 20% of the left ventricle. So from here we are going to move, have some practice. What we have discussed. You have 3 minutes to read this scan and write your comments in the chat box quickly. 3 minutes. So 1.5 minutes has passed. Anyone? भले गलत लिखे कोई मसला नहीं.
Dr. Danish, you want them to write in the chat box or you
Any-
want them to come? Because we have some people on the
Whatever they like. If they
Alright.
want to just report it directly, then they can.
All right, Dr. Abrar.
हेलो अस्सलाम वालेकुम.
वालेकुम सलाम.
आवाज आ रही है मेरी?
जी जी बिल्कुल आ रही है आपकी आवाज.
अच्छा, ये दिस सीम टू बी अ नॉर्मल. अच्छा, दिस सीम टू बी अ नॉर्मल परफ्यूजन स्कैन. इसमें हमें कोई डिफेक्ट्स नहीं नजर आ रहा. अगर हम इंटीरियर या इंफीरियर लेटरल और सेप्टम एरिया को देखें शॉर्ट एक्सेस में या
Okay,
वर्टिकल
all
और
right.
हॉरिजॉन्टल एक्सेस.
All right, upright. Anyone else?
Dr. Ahmed,
Hello.
would you like to comment? Yes, Dr. Shams, please go ahead.
अगर if we look into the short axis, तो जैसे हम mid, अगर मैं इसके कलर को देख लूँ तो पार्शियल परफ्यूजन डिफेक्ट जो टेरिटरी है ना, वहाँ पे रेस्टिंग और स्ट्रेस दोनों में नजर आ रही है. और अगर मैं वर्टिकल लॉन्ग एक्सिस में देख लूँ तो वहाँ पे भी 1 2 3 4 को अगर मैं रेस्टिंग पे और स्ट्रेस पे देख लूँ, यस दिस वन, तो ये भी पार्शियल है बेस्ड अपॉन द कलर. ठीक है. बाकी अगर मैं हॉरिजॉन्टल को देखूं तो उसमें मुझे कोई परफ्यूजन डिफेक्ट एंड पे मुझे लेटरल पे मिल रहा है एट द एंड यहाँ पे नहीं. हाँ, एंड पे अगर मैं
But you have to
उसको देखूं
again
ये
compare it from the
yes.
short axis, so it's likely not over reporting हो जाएगी थोड़ी सी. ठीक है. So
so
good.
मुझे सिर्फ यही नजर आ रहा है पार्शियल
How are
परफ्यूजन
you
नजर
are
आ रहा
going to write it now? आप इसमें क्या क्या
है.
बताएंगे
मैं
आप?
इसको
Defect.
partial
First thing is-
perfusion defect of mild severity and inferior territory.
So where it is
Both
present, if these are the apical segments,
inferior
It's not in the apical region.
inferior
It's the mid cavity
apical
level.
में
Mid
mid
cavity
cavity
level.
mid cavity
Yes.
level mid cavity
Okay.
level
At the basal level.
base पे base पे भी है, yes, at the base
Yes,
also.
So if it is at the mid cavity level and the basal level, then it's going to make how many segments?
2 segments.
2 segments. It's only in the inferior, no septal, no inferoseptal. All right.
Yes, so it will
Okay.
be mild.
So it's a small size. It's
Yes, it's a
small
it's a small
size.
size.
Okay. And
Yes,
moderate severity.
and partial perfusion defect.
It's a small size.
Moderate severity or mild?
severity. It's moderate. We have it's like
yes,
if I
yes,
follow the color
moderate
here,
severity.
it's like that. Okay. For severity. Of
Yes,
moderate severity, both at stress and rest. Okay. The defect is
Resting.
present at both stress
Yes.
and rest. It means it's irreversible.
Yes, it's irreversible.
Rest. All right. So how you are going to write it?
Okay.
It's a small size, moderate severity. The person there is present a perfusion defect both at stress and rest involving mid inferior and basal inferior segments. Involving mid inferior and basal inferior segments. All right, everyone. All you reported. Okay, move on to next one. Again, you will have 3 minutes to report it. Your time starts now.
Hello.
Yes. Who is this?
Dr. Danish, it's me, Dr. Shams. Should I comment on this again?
शम्स किसी और को भी मौका दो हमारे पास बाद में
Okay.
आते हैं
Yes.
let someone else comment.
Dr. Ahmed has unmuted his mic. Dr. Ahmed, do you want to comment on this one? Dr. Ahmed, are you there? Ahmed, Muhammad Ahmed. I guess he's not here. All right, you still have a minute and a half, so anybody else can comment too.
Just step forward. I will correct you. Or you can write it in chat box. 2 minutes have passed. People have started to leave. भाई जाने की जरूरत नहीं है जवाब नहीं देना तो ना दो सीख तो ले Okay. Anyone? Avinash is saying
Doc-
small size
yes.
defect in basal inferior. Okay. Anyone else? Moderate, non-reversible. Sanya is saying inferior, moderate, small size defect. Inferior, basal, mid. Small size, fixed perfusion defect, mid inferior, inferior basal segments. Okay. All right. So let's see. What is it? Again, if there is a defect, yes, there is a defect. Okay, first thing. So now where the defect is, you have to localize it. The defect is present at apical inferior. Yes. Then from apical inferior, move to at the cavity level, mid inferior. Yes. At the rear, yes. So inferior, you can confirm the defect. Is it inferior? Yes, inferior. Any defect in the septum, lateral? No, no. Any defect at the apex? No. So how many segment it has involved now? Apical inferior, 1 segment. Mid inferior, 2 segment. Basal inferior, 3 segments. So 3 segment means it's a moderate size. So, and whether it is reversible? No, it is not reversible. Present at stress as well as rest, and it's almost of this color. So it's almost of a moderate intensity. Okay? So there is present a fixed perfusion defect of moderate severity. There is present a fixed perfusion defect of moderate severity involving a mid inferior and basal inferior segments. Involving apical inferior, mid inferior and basal inferior segments. Okay, so you have told the size of the defect, the location of the defect, and severity of the defect. Of moderate severity in apical inferior, mid inferior, and basal inferior segments. Is there any cavity dilatation? To label cavity dilatation, it has to be dilated at least 25% during stress. So no, as such, no cavity dilation is present both in stress and rest images. All right, fine. So moving on to next one. Okay, again you have 3 minutes to report it. Yes, 19 seconds have passed. Anyone? Moderate to large fixed defect. In inferior, inferolateral, and basal segments. Mid inferior, mid inferolateral, basal inferior, basal inferolateral, both at rest and stress, showing moderate, large size, fixed perfusion defect of severe intensity involving apical inferior, mid inferolateral, and basal inferolateral. Arshad, very good. थोड़ा सा missing है, लेकिन it's very good. Abrar, fixed perfusion defect in inferior and inferolateral area. देखिए area का word नहीं segment. Use the word segment. ठीक है, प्रॉपर वर्ड्स यूज करें और जितने सेगमेंट्स हैं सब लिखें, शॉर्टकट नहीं है कोई। So okay, start reporting it. So again, is there a defect? Yes, there is a defect. Is that defect is reversible? Not reversible. So what how we are going to start writing? There is a fixed perfusion defect. There is a fixed perfusion defect. अब size decide कर लें, उसका size कितना है? It's present in the apical inferior. Yes, one segment. Then from here move to the cavity level. So at the cavity level, is it present? Yes, inferior and inferolateral. So at apex is one segment. Then when you come to cavity level, inferior is again a second segment. Inferolateral is third segment now. And at the basal level, as you come further, inferior, inferolateral, inferior, inferolateral. So these are two separate segments, two segments, and one segment. So there are five segments. Five segments mean large size perfusion defect. So there is a fixed perfusion defect of large size, and what's the severity? Take a high severity. Okay? It's almost blue, no uptake. There's a fixed perfusion defect of large size of severe intensity involving apical inferior, mid inferior and inferolateral, and basal inferior and inferolateral segments. All right, everyone, how we are going to report it? There is present a fixed perfusion defect. There is present a large size fixed perfusion defect of high severity of severe intensity involving apical inferior, mid inferior and inferolateral, and basal inferior and inferolateral segments. All right, moving on to next one. Okay, report it quickly. Yes. Umesh is saying small size fixed perfusion defect of apical and apical septal segments. Apical septal ये क्या होता है? Apical septal तो मैंने नहीं बताया. Yes, anyone want to speak out? Small size fixed perfusion defect of high severity involving apex. अच्छा.
Hello,
Yes. Again,
Dr.
it's
Danish. There is a moderate
done.
size partial reversible, yes, partial perfusion defect involving the apical anterior segment, and also there is another partial perfusion
Apical
defect
anterior.
at the, yes, apical anterior.
नहीं, apical anterior तो हमने कोई segment नहीं बताया ना. Apex is a
देखो
separate
जो शार्ट
segment.
एक्सिस, sorry, apex,
Apex,
sorry, apex,
apex is a
yes,
separate segment. Okay?
yes, at the apex, at the short axis level, and also another partial perfusion defect at the basal level involving the anteroseptal and inferioseptal segment.
Hmm.
That's also a
Okay.
partial perfusion defect.
Okay. Okay. If it's belonging to a same, what you people think? The defect you are seeing in this scan belong to a same vessel territory or different vessel territory? What are the segments? Anterior, anteroseptal, and the apex. Are these supplied by single vessel? What do you
LAD,
think?
yes,
Okay.
LAD,
So when it
LAD,
belongs to single vessel territory, so that is going to be considered as a one defect. That all is going to be considered as a
Okay.
one defect. Okay. So then it's
One.
going to be a large defect. Okay. So where the defect is located? Acha, here I think there are few segments which are missed because starting from 9, apex is missing here. So we consider there is apical anterior, then mid anterior, 2, and then there is some defect here as well in the septum. Okay, apical
Yes.
anterior, or it's mainly it's a cavity level. So it's mid anteroseptal, apical anterior, likely is apical septal as well. I think because septus few slides segments are missing, and then there comes this defect. Okay, anteroseptal. So 1, 2, and then move on to the cavity level that is persisting. The basal level is basal level. There is as septum is already turning into membranous one, so there is not at the at the basal level. So considering it at the apical anterior, anteroseptal, mid anterior, anteroseptal, and the apex, then these are 5 segments now. So when it is 5 segment, so there is present
Large
a
size.
large size. There is present a large size, and again, if you compare it at stress and rest, there is no change. And what is the intensity? It's high severity. So there is present a large size fixed perfusion defect of severe intensity involving apical and apical anterior and septum and mid anterior and anteroseptum and apex. All right, everyone. There is present a large size fixed perfusion defect of severe intensity involving apical anterior and septum, mid anterior and anteroseptum, and apex. Okay, move on to next one. Again, you have 30 seconds. You have 3 minutes to report it. Yes, anyone? There are 3 minutes means that you have to read it and report it. You have to done it within 3 minutes. Ninety seconds.
Hello.
Okay, Arshad, yes. So it's a large size reversible perfusion defect of severe intensity involving apex, mid-inferior and inferolateral and basal inferior, inferoseptum and inferolateral segments. Very good. एक चीज मिस की है अर्शद, दो चीजें मिस की हैं। अब्रार को सिर्फ एक ही चीज नजर आई खाली, डायलेशन। You don't write dilation of LV, cavity dilation. Again, you don't write it cavity dilation. You write it as stress-induced cavity dilation. Use of proper terms is important. Yes, anyone to speak out? Okay. Anyone want to speak?
Dr. Shakir, you wanted to, I guess. Dr. Shakir, are you there?
Okay, we can done. Just moving it quickly. ये NICVTs का पुराना प्रॉब्लम है, बोलते नहीं है। चले। All right, so there is a defect. Yes, there is a defect. Okay, and this defect is reversible as well. So starting from what is the location of the defect is? This is the apical area. So it's starting from anterior here. Okay, the defect is present in the anterior, apical anterior, apical septal, inferior as well, lateral, moving further anterior septum as a good uptake, inferior, anterior, inferior, anterior, inferior. So we have to confirm these defects here as well. So the defect is in anterior, yes, apex, yes, defect is and inferior. So there is defect in the anterior wall, apical region, and the inferior one. And similarly, confirming these defects in the horizontal long axis, apex, septum, lateral. There is in the septum, yes, there is a defect in the septal area, septal. So the defects is in anterior, septum, and the apical regions. Mainly the defect where it is residing. So start describing it. There is present a large size ticket involving multiple segment. There is a large size. There is a large size reversible. As we are seeing at rest, it has a better uptake. It's a normal uptake given, and here showing a very good uptake. And at stress, the uptake was severely compromised. So there is a large size reversible perfusion defect. There is a large size reversible perfusion defect involving apical anterior and apical septal mid anterior, mid anterior, mid anterior, okay, mid anterior, and apex. Okay, I'm not describing inferior here because I cannot describe inferior with
Dr. Danish? Dr. Danish? I guess Dr. Danish is having some connectivity issues, so we'll wait for a couple of minutes.
okay. Sorry, had lost the connection. Sorry for the interruption. So just we were started to reporting it. What I said, as the defect lies in two different territories, how we will describe? We will describe in two steps now. So first we will describe the defect of the LED territory, and then we will describe the defect of RC territory. So the defect is there is a large size reversible. There is a large size reversible perfusion defect of high severity involving apical anterior, mid anterior segment and apex. Apical anterior, mid anterior segments, and then we will describe the inferior one. There is present a large size. There is present a large size perfusion defect of high severity involving apical inferior, mid inferior, basal inferior, and inferoseptal segments. Apical inferior, mid inferior, basal inferior, and inferoseptal segments. Second thing, third thing फिर आप बताएंगे इसके अंदर there is also stress induced cavity dilation. There is also stress induced cavity dilation. Noted. ठीक है, तो आपने इनको तीन स्टेप्स के अंदर इसको बताना होगा. ठीक है, नेक्स्ट वन. So we have done with the reporting part. यहाँ तक कोई problem किसी को? Any questions, any queries you have till now? You have understand how to report and scan?
Dr. Danish, I guess it's clear. Here you can
So we can
proceed,
move
and then
further.
they can write the questions in the. You
Okay,
can take the questions.
fine.
in there.
So highest features of SPECT MPI, resting perfusion abnormalities of 10% of the myocardium in patient without prior history or evidence of MI. And on rest you find perfusion or 10% of the myocardium means simply okay, 3 or 4 segments. If stress induced perfusion abnormality
Dr. Danish,
Yes, yes.
we lost your voice. Can you please repeat?
Okay. These are the few high risk features of SPECT MPI. Okay. Of these abilities involving 3 or 10% means 3 or 4 segments, okay? Or stress induced 3 or 4 segments. Stress induced LV dilation, increased lung uptake. Increased lung uptake is a feature of thallium scan, not on technetium one. LVEF less than 35%. So all these are high risk features on SPECT MPI. Okay. So before proceeding further, going a bit back on previous slides, which we had left. So there are few contraindications for stress imaging. You should remember these. Patient with unstable angina, high systolic blood pressures with ongoing arrhythmias, severe symptomatic aortic stenosis, pulmonary embolism, acute myocarditis, pericarditis, and a myocardial infarction within 48 hours. So these are few contraindications for it. And when to stop for the patients for early termination of the test. You don't target 85% of the age-predicted heart rate. If any of these started to occur, we should be concerned about patient safety as well. So patient is having severe angina, started having dyspnea, fatigue, patient get ataxic while doing exercise, developing signs of poor perfusion, patient request, excessive ST depression start to come on ECG, ST elevation, having some arrhythmias begin to occur, development of LVP or IVCD that cannot be distinguished from ventricular tachycardia at a higher rate, drop of systolic blood pressure that indicates again high risk ischemia, hypertensive response of systolic more than 230, inability to monitor the ECG change when the heart rate attained is within 20 beats per minute of the lowest heart rate at which therapy is programmed to be delivered. Means if anti-tachycardia pacing or shock is programmed to deliver at 150 and heart rate is going to achieve that, then you have to stop this to prevent the shock. Okay, after this interpretation, you should remember there may be some false positive results that may be because of attenuation defect, because of diaphragm or the breast tissue. The image acquisition from the SPECT machine may be less, that can show a defect, but it's actually not there. How will you differentiate it? Okay, if there is a defect on the myocardial perfusion scan, but you are calling it that defect is false one, attenuation, that you are saying there is a defect in the inferior segment, but that inferior segment defect is a false defect. How will you can answer this? सभी sections में आएगा अगर वो है एक चले, और इसके अलावा what else? Or any other from seniors? Or will you say it's a false defect? Prone position is used to overcome the diaphragm effect, okay? But it will not distinguish whether it's a true defect or a false defect. The way we are going to detect this, use a gated imaging, means use it with the ECG. Use with the ECG, and you are going to look at the wall motion abnormalities. If there is a defect and a wall motion abnormality as well, it means that it's a true defect. If there is a defect but no wall motion abnormality, it means it's a false defect. And it can be false negative as well when the stress is not given adequately, as discussed by Dr. Zahid. If patient is initially asked to exercise but is not able to achieve that age predicted heart rate, then shift it to a pharmacological one. If patient is already on anti-ischemic medical therapy, if has a good collateral circulations, then You will have negative result, false negative results. Presence of balanced coronary stenosis. What is balanced coronary stenosis? Keep it in your mind that what we are appreciating is a difference. Okay? Here is a brighter spot, there is a less brighter spot, there is a brighter spot. So we are going to appreciate the difference. If it is less bright, it is less bright, it is less bright, it is less bright, then all is going to appear as the same one. वो सब एक ही जैसा दिखना शुरू हो जाएगा. ठीक है? That is called balanced ischemia. And there is a ischemia, but there is no difference in between adjacent parts of the myocardium, so you cannot appreciate the difference. That's called balanced ischemia, which is in triple vessel disease. You will have a false negative results, or if you are imaging it after giving isotope at a far later time. Okay, so we have done with the basics of the MPI, exercise versus pharmacological interpretation. I think you have understood, and then finally move on to few applications of it, when we can use it. So non-invasive testing for ischemia should be performed before discharge to assess the presence and extent of inducible ischemia in patient with STEMI who have angiography and do not have high risk clinical feature for which coronary angiography would be warranted. Anyone, ये कौन सा मरीज है हमारा? किस मरीज की बात हो रही है? यानी a patient जिसको commonly हम क्या लेबल कर देते हैं? लेट अराइवल. कि भाई ये पेशेंट आया लेट अराइवल के साथ है, लेकिन उस लेट अराइवल में भी इंडिकेशन है कोरोनरी एंजियोग्राम की कब? व्हेन पेशेंट हैज चेस्ट पेन ऑन मिनिमल एक्सर्शन, तो उसकी एंजियोग्राफी वैसे भी हो जाएगी. कह रहे हैं कि भाई स्टेमी है हु हैव नॉट हैड अंडरगोन एंजियोग्राफी, अभी तक एंजियोग्राफी नहीं हुई, एंड डू नॉट हैव हाई रिस्क क्लिनिकल फीचर्स, उसको पेन भी अभी तक नहीं हुआ, तो उसको डिस्चार्ज करने से पहले आप क्या कर लें? उसका एक एमपीआई करके देख लें कि जो सिवियरिटी ऑफ इस्कीमिया कैसी है, इट्स अ रिवर्सिबल डिफेक्ट और नॉट, to decide for the further thing. Where non-invasive testing for ischemia might be considered before discharge to evaluate the functional significance of an infarct artery stenosis previously identified at angiography. And if there is a 70% stenosis or 80% stenosis, it is produced for inducible ischemia. Next one, as pharmacological stress testing with imaging is recommended when physical limitation preclude adequate exercise. This is for the pharmacological one. Whenever it is possible, do exercise MPS, because exercise MPS is physiological one. It gives you better idea about patient pain, patient exertion, patient symptoms. Pharmacological one is not physiological one. It's not going to give information about the physiology. When patient is going to walk, what happens with the patient. So whenever it's possible, go for physiological or the exercise testing, but if there is contraindication, then go for pharmacological test. Similarly, risk stratification before discharge की बात हो रही है. Stress testing with an imaging modality should be used in patient who low level exercise stress test and imaging modality can add prognostic value. ठीक है, तो फिर वो पेशेंट जिनको आप किसके लिए रख रहे हैं? इस्कीमिया गाइडेड स्ट्रेटेजी के लिए. ठीक है, नॉन एसटी के अंदर डिफरेंट स्ट्रेटेजीज आपके पास हुआ करती हैं. तो द पेशेंट यू हैव डिसाइडेड नॉट टू डू अ कोरोनरी एंजियोग्राम एंड पुट ऑन इस्कीमिया गाइडेड स्ट्रेटेजी, इन मरीजों के अंदर भी आप MPI करके डिसाइड कर सकते हैं. If ischemia burden is high, less than 10%, you can put on medical management. More than 10%, do a coronary angiogram and decide about revascularization. Detection of concomitant coronary disease in SCM. In SCM patient, as you know, there is hypertrophy of the myocardium, commonly left ventricle, main wall, right ventricle as well. So these patients commonly present with chest pain. At a younger age, to rule out coronary artery disease, you can do a MPS for a perfusion defect. But keep it in mind, if that MPS is normal, if that MPS in a SCM patient is normal, means no perfusion defect, it has a high negative predictive value to rule out coronary artery disease. But if it is positive, and then it can be positive because of the increased demand of the positive predictive value, then you have to do a coronary angiogram to rule out the coronary artery. But if it is negative, then it is a high negative predictive value in a SCM patient. Then for detection of CAD, we exercise stress with nuclear MPI or echo is recommended for patients with intermediate to high pretest probability of ischemic heart disease who have an uninterpretable ECG and at least moderate physical functioning or no disabling comorbidity. Means if a patient has presenting to you for with chest pain and you want to do a non-invasive testing, the first test to do is ETT. Okay? If patient has ECG which is not interpretable, have LVB on the ECG, or have some WPW, or have some digit factors going on, has LVH with a strain pattern, some uninterpretable ECG, then you can go for imaging modality to rule out ischemia. Okay, and it's never been an initial test. Okay, don't use it as a initial test in low risk patient. Okay, it's for the intermediate to high risk category. If patient has an interpretable ECG, low to moderate risk of ischemic heart disease, then go for ETT first, as per AHA guidelines. And then pharmacological stress with nuclear MPI or echo is recommended for patients with intermediate to high pre-test probability of ischemic heart disease who are incapable of at least moderate physical functioning. So when you will go for pharmacological testing, when patient has moderate physical functioning, has arthritis or is complaining that get easily short of breath or will not be able to exercise much, then in such patients you are going to opt for pharmacological tests. So when you are going to prescribe, ask patients how much they can walk, whether they can brisk walk or not before prescribing it as a exercise MPS. Otherwise you have to prescribe as with dipyramidamole in our setup. Okay, you can do it for risk assessment as well. The stable ischemic heart disease, a patient who has undergone PCI 5 years back and or CABG 5 years back, and you now want to understand or just stratify them whether there is a ischemia or not, then in such patient you can also use MPS for the risk stratification purpose. Okay? In stable ischemic heart disease who are being considered for revas of known coronary stenosis of unclear physiological significance, means if there is 60% or 70% stenosis previously present and you want to know whether it is producing any ischemia or not. Or even from the ESC guidelines, even it is less than 90%, between 70 to 90, you still want to know the physiological significance either invasively with FFR or IWFR or non-invasively using MPS. And those with stable ischemic heart disease who have new or worsening symptoms, complaining about they were very good walking 15 minutes or 20 minutes and now started having symptoms for 10-15 minutes. So to know the ischemia burden in such patients, you can also use this MPS. I guess we have done with it now. Any queries you have now?
All right, thank you, Dr. Danish. That was amazing. And we do have some questions in the question and answer section, but they are kind of, most of them are repetition of what you have already explained, but since they have mentioned it, so maybe you can just describe them precisely.
How to tell if LV dilation we had discussed is more than 25% from the baseline, from the RAS images, then you will see it's LV dilation. If we have a large size perfusion defect of high intensity at rest, and we don't want our patient exert because of defect at rest, how will be known it is reversible or not? But if there is present already a defect at rest, what you want to know is viability. Then you have to give nitrates to the patient. In that case, you don't have to give any stress to the patient. I think you are confusing something. So for that question, what I have understood, what you want to ask, if there is present a defect at rest, so it means there is already a defect. What you want to know is viability there or not. You don't want to give further exertion to the patient to know whether it's going to further get worsened or not. You give nitrates to the patient and see whether it's improving or not. So you want to check viability, not ischemia in such cases. And Shams is asking which one is more pharmacological, physiological. I think I have answered it. Physiological exercise stress testing is more of clinical importance as compared to the pharmacological. Any other questions?
We don't have any more questions, Dr. Danish, in the chat box as well.
Dr. Zahid, if you want to add anything. I think Dr. Zahid is not here.
Yes.
Okay. If there are no queries, then we can stop here with them.
Yes, we can probably end the session.